So, having finished the entire ECG course, I will go through the steps and summary of ECG reading. So, before touching the ECG, please remember you have to clinically examine the patient. We have a good clinical data before we record an electrocardiogram. So, please remember to correctly connect the electrodes and correctly place the chest electrodes on the appropriate places to record the correct ECG. Please connect the electrodes properly, because we have already told you how to test a technician is to ask him to place V3. The V3 should be placed between V2 and V4. So, teach the paramedics according to the color. So, we told you about the V1, V2, V3, remember the traffic signal, and for the V4, V5, V6, we told you to remember the BOP. And all ECGs, we must have the clinical details of the patient and what age and what the sex of the patient. Then you look at the standardization, 10 millimeter standardization, and the speed of recording of 25 millimeter per second speed. So, without never interpret an electrocardiogram. We'll start with the P wave. P wave is due to atrial depolarization. So, when the P waves are tall, it is right atrial enlargement. P waves are wide, it is left atrial enlargement. When the P waves are inverted in inferior leads, P waves are inverted, you must see where they are inverted. If they are inverted in L1 and upright in AVR, you must suspect either Dexocardia or technical Dexocardia. So, you can see that here the P wave is inverted in L1 and upright in AVR. So, but look at the chest leads. The left-sided chest leads have got no QRS, whereas right-sided chest leads have got progression of R wave. That means your heart is on the right side. So, this is a true Dexocardia. Whereas, when you have a P wave, so in limb leads, when a P wave is inverted in L1 and upright in AVR, look at the left-sided leads and the right-sided leads. If the R wave is progressing in the right-sided leads, it's a true Dexocardia. Whereas, look at this ECG here. Here, the P wave is inverted in L1, upright in AVR, but the QRS is progressing normally over the left-sided leads. That means your left heart is on the left side. Here, it is appearing like a Dexocardia because of the limb lead reversal by the technician. So, this is called technical Dexocardia. So, true Dexocardia, the R wave will be progressing on the right side. In a technical Dexocardia, R wave will be normally progressing on the left side. So, if the P waves are absent, it can be atrial fibrillation or sinus pause. If the P waves are occurring on a T wave or the ST segment, most often you are dealing with an atrioventricular dissociation. If the P wave is abnormal in shape, I told you about atrial premature beat, or in atrial tachycardia, in atrial flutter, the P waves will be abnormal in shape because the depolarization is occurring from atrial ectopic pacemaker. If the P wave is not followed by QRS complex, suspect atrioventricular block, which can be third degree or second degree atrioventricular block, which can be complete heart block or secondary atrioventricular block. So, this is about the P wave, absent, occurring on a T wave, abnormal in shape, not followed by QRS complex. Then look at the PR interval, normal PR interval 0.12 to 0.21 second. If the PR interval is too long, it is a first degree atrioventricular block. Then look at the QRS. If the QRS is wide with the first degree atrioventricular block, it is infra-His delay. So, you have to have an aggressive management. If the PR interval is too short, it can be a WPW syndrome or pattern, presence of Kent pathway bypassing the AV node. So, if the patient has got a tachycardia, it is WPW syndrome. If the PR interval is varying, it could be an AV dissociation of either complete heart block or ventricular tachycardia. If the variable PR interval is happening, so the PR interval is not constant and is continuously varying, it is an AV dissociation. If it is a bradycardia, it is complete heart block. If it is a tachycardia, it's VT. Then we come to the QRS. Any Q wave is present. So, please remember, it is physiological versus pathological Q wave. Pathological Q wave represents chronic total occlusion of infarction.